Good morning. Hey, Dr. Phillips, I'm recording this session because there's a lot of people who wanted to be a part but had a conflict.
No
So I've
problem.
already started the recording.
Okay, hi everybody. I'm so happy to be here with you. Just so that I know, can you guys shout out what counties you're from before we get started as I'm sharing my screen?
Marion County, Ocala.
Excellent.
Volusia County.
Volusia.
Knoxville County,
Says it.
Clay
Gulf
County.
County.
Citrus.
Citrus County.
Gulf County.
County.
Pinellas.
Brevard.
Duval.
County,
What was that last one?
Clay. And Duval.
and Pasco.
Broward.
Excellent. So a lot of counties here. Thank you guys so much for coming.
Flagler as well. Sorry.
Flagler, excellent. Give me a second, Shannon, let me see. Okay, so can you guys see my PowerPoint here?
Yes.
Okay, so I want to start with, there was a brave person from one of the counties who admittedly said what we're struggling with on the clinic side is, first of all, there's a lot of patients who need help. We all struggle with staffing. We definitely want to give them medications, but some of these patients, they get the medications and they continue the cycle over and over again, and they keep circling through with, outside of staying alive, little improvement. Now, so this discussion was generated as and a couple of years ago, I had the same issue at the tail end of COVID. Can you hear me? Sorry. I had the same issue at the tail end of COVID with burned out staff, lots of patients to see, poor cycle times, and how to keep slots open for lots of return visits as we kept collecting more and more people who needed help. And we wanted to keep the doors open. So this talk is generated as a concept model for you to keep that throughput and provide high quality care. We know that we don't want to stop medication just because someone's not willing or can't have access to psychosocial treatments. But a lot of us know the data too, that retention improves and the long-term outcomes can improve with some psychosocial intervention along the way with the MAT. So how do we marry those two concepts, okay? So today, I'm gonna give this lecture of what we've done and what we've seen and give you guys some ideas on that. And also, I would really like this to be interactive because a lot of you on this call are in clinics with providers, both on the mental health counseling side, social work side, and the prescriber side. And this is a chronic frustration. So let's look at the history. Historically, psychosocial interventions were the only treatment for substance use disorders and still are the only treatment for some substance use disorders. Medication-assisted treatment for opiate use disorder showed superior evidence than no medication assistance in terms of mortality and retention. And I think some of my previous talks shows the data for that. There's lots of data for that if you're interested in seeing that. Originally, when you got an X waiver for buprenorphine, it originally, many years ago, required that you did psychosocial treatment along with giving buprenorphine. That was a challenge for a lot of prescribers who didn't have access to psychosocial treatment, and getting psychosocial treatment is actually very difficult, especially from a primary care setting. Methadone clinics have been around since the 70s. And in those clinics, that's an MAT that's been around for a very long time. So psychosocial intervention is still required alongside methadone prescribing. So those clinics are subjected to that. So that's the history. The problem, which many of you guys are fully aware of, is mortality rates from opiate use disorders have rapidly increased, requiring a rapid system-wide response, which is why CORE was put in place. Psychosocial intervention studies have been lacking definitivity. Sorry about that. But if you look at a lot of the studies, CBT and motivational interviewing and contingency management are the three modalities that do show some promise. Psychosocial treatment with MAT is shown to increase retention in outpatient-based opioid treatment programs, but studies also show that MAT alone is superior to nothing, and the lack of psychosocial treatment shouldn't stop medication-assisted treatment. So that is why a lot of the grants are saying you can't, if you give MAT, you can't require anything alongside it. We want it to be a low barrier care so that we save lives. And the spirit of that is mortality improvement, right? So having people stop dying is the issue there. But I'm a psychiatrist, and I had problems with that because I said, okay, I am all about people living, right? And I'm sure a lot of you guys are on this call are feeling the same way. But I had droves of patients who weren't thriving or living a meaningful life because I could see in the office that they lacked coping skills that they had not developed for the decade that they've been using or the 5 years, and they needed help with that. The other problem is finding qualified mental health staff comfortable with working in substance use disorder clinics. And the demand for patients far exceeds the amount of mental health providers to provide one-on-one counseling to each patient. The other problem is when a patient gets sober, they often lack coping skills necessary for everyday life, which contributes to the relapse and makes the case for using CBT and motivational interviewing to develop these skills. The last problem is staff gets burned out from the person who, and I think somebody on the call, I think it was Deborah, was so brave to admit that I get tired of the patient relapsing every other day. Yes, they're alive, but they're still using fentanyl and they're still here and they don't seem to be making progress in their life skills. So, and that burnout can lead to people quitting and moving out from the field. So all of these things have to be considered so that we can continue to take care of these patients and try to reach their goals. Is anyone on this call aware of any other problems that they face in terms of trying to marry psychosocial treatment with also the life-saving intervention of MAT? Anybody else want to bring up another problem? Okay. And like I said, you don't have to raise your hand. You can just unmute yourself and speak. So when I was facing this problem, and I'll be honest with you guys, I'm here to be very transparent. I ran a clinic model that was very similar to what you guys are doing in your different groups. Ours was an FQHC model with primary care, but this can work in a CMHC model. I started to look to the literature because what happened to me is at the tail end of COVID, staff was burning out. We had very long cycle times. Patients, we were having lots of incidents with patients waiting too long and getting agitated. And we also had staff saying, this is too much. I'm exhausted, I'm leaving, because there's no, it's always chaotic in our waiting room. So I said, well, we got to do something. So I said, let me look to the literature and see how they're solving the problems in the literature. And I came up with these two models that I started to read in depth about. There are other models that I'll point to in a second, but this is the ones I sort of looked at. And it was called Building a Group-Based Opioid Treatment Blueprint, a qualitative study delineating GBOT implementation by Sokol. And you can see Sokol's on both articles. And then there was a review done. And I was very compelled by what they were saying in this article. I highly encourage you guys. It's about 6 pages. It's a great article to read. And it's very practical. So it doesn't matter if you're a physician or a social worker, or I highly recommend that you read this. And in the model, they talked about basically saying, instead of doing return visits with the prescriber and then also giving a return visit with a social worker or a licensed mental health counselor, combine the visits. Combine the visits where the patients are getting group, and during group, they're being pulled out and they're being seen by the prescriber quickly. Now, these were some of the components, the 6 components that they said would be successful according to their research paper. The only difference that we did is we do a 99212 visit, and I'll talk about that later. But the patient gets a consistent application of expectations. There's group roles, like there are in many groups. There's a team-based approach. So we have medical assistants, front desk, nurse, and it's a very well-oiled machine now in our clinic 2 years later of all of the front desk, the MAs, the prescriber, and the social worker. It creates a safe and confidential space where the patient gets a meaningful psychosocial intervention while they're doing their medication visit, and they still get their regular monitoring. So at the beginning of group, all the patients are drug screened before group starts, and it helps them have regular attendance and participation because it creates an organized frame for the patient. Okay. What I told you at the beginning was there are other models for this. I really thought that this model would help us solve our particular problems, and I'm presenting that to you today. But there's also medication-assisted treatment models of care for opiate use disorder. I just found this recently, and it's fantastic overview. It's 122 pages, but it discusses lots of different models that the AHRQ has recognized in the literature, and summarizes a lot of the literature for models of care in primary care settings, which could also be applied to community mental health clinics as well. Okay, so any questions on the background of that? Because we're going to get into the actual practical flow of this as well. Okay, so let's apply this theoretical stuff to actual clinic flow. So what we do in our clinic, and I'm just telling you this is the receiving clinic, okay? So this is after the emergency services, this is after EMS, this is however they present to us, or if they're just a walk-in. Their first 3 weeks, they are not seen in the group-based addiction treatment model. We call it group-based addiction treatment because we also include all substance use disorders into that group, not just opioids. So week 1, they do a new intake or readmission, whichever it is, and there's a lot of readmissions as we discussed before. They see the nurse, social worker, or LMHC to start their biopsychosocial, and they see the prescriber to get immediately started on MAT and stabilized. We see them day 3 for a nursing visit to do a dose check and adjust the dose, as well as provide education to that patient and their family. So the nurse actually does the education here. She's trained, she has lots of materials, and she'll go over things with the family and the patient so that they feel comfortable. The reason we do that education on day 3 is often day 1, they don't feel good. We make their day 1 visit quick and efficient with not a lot going on, because a lot of them are in withdrawal still. So this is not a time to have a deep discussion about the concept. So we do more of that on day 3. In the second week, in our clinic, they see a prescriber for a primary care visit, and it's a primary care provider who does a dose adjustment or making sure how they're doing on their MAT. A lot of the patients also are getting benzo tapers because they've been abusing those as well. So we're working on tapering those slowly. And we're monitoring their withdrawal for benzos or alcohol as well. And a social worker or LMHC will also individually see them, because this is going to be the same person that saw them in the first week. The patient is typically feeling better and they're more receptive to talking more. And they can fill in parts of the biopsychosocial or the treatment plan that weren't able to be done in week 1. And then primary care does their first primary care visit, because a lot of these patients haven't seen primary care ever. The primary care doctor gives them their MAT, but they'll do a thorough established care visit, and they'll schedule follow-up for that as needed as a separate visit. The third week, they see the psychiatrist or the psych A&P for MAT, and that MAT psychiatrist is able to give them their Suboxone or continue their benzo taper if that's still in play. And they also do a psychiatric evaluation. They determine if that person has underlying psych issues, and that psychiatry, that they schedule telepsych follow-up as needed for that patient outside of group-based addiction treatment. And then week 4 and beyond, all of the medication-assisted treatment is provided in group-based addiction treatment, or GBAT. Any questions about that? So again, that first 3 weeks, it's all individual visits, and that's where we spend our time. So I want to show this table. This was phases of treatment that we ascribe to. So we have people on 1 week of medications in phase 1, 2 weeks of medication in phase 2, 3 weeks of medications in phase 3, and 4 weeks of medication in phase 4. Phase 4 plus is a delineation that our patient is so stable they can go to the outer primary care clinics that have primary care providers that will just continue their medication-assisted treatment along with their regular primary care follow-up. But phase 4 plus patients no longer come to our specialty services clinic, which has the fully integrated substance use, psychiatric, and primary care. Okay. So this is something that we've done. So in phase 1, the patient comes to group-based addiction treatment weekly. They get weekly amounts of medication. They have to get and in order to go to 2 weeks of medication, they have to be sober off of everything except for cannabis. We've allowed THC. They get a live visit in the group-based model every 2 weeks. We used to do in between, we're just changing this. We used to do an in-between Zoom group, which I'll talk about. If you're on phase 2, you get 2 weeks of meds, so you come in every 2 weeks live, and the week that you're not there, you do a Zoom group that is also in line with the group. But we're starting to change that because our data is supporting that we might not need that. And as you can see, they come live every 3 weeks and live every 4 weeks. If a patient is at 3 weeks and they come to the clinic and they've relapsed, that's okay. We just move them to 2 weeks and we see them 2 weeks later. And the same goes to 1 week, but if they're able to get it together for the next visit, then they go back to 3 weeks. So this is our small part of contingency management that keeps the patients having some accountability. The other thing that happens a lot is patients might come in sober, but they're 4 days late for their appointment. We will face them down for that because the question becomes, how are you getting the medications? Many of them are buying it off the street or stretching their doses. If they keep coming 4 days after their original visit and they're sober and they're not in withdrawal, what we do is we adjust their dose down by 4 milligrams because oftentimes it means they're stretching, they don't need the amount. And that's how we do that. And with that in mind, I don't want to talk about dosing, but we do dose high for fentanyl. I don't want to get into too much with this, but do you guys have any questions about this table?
This is Jesse from Ocala
Yes.
Fire Rescue. Are you guys, is part of your inclusion criteria that they have a home or apartment or shelter to go to? Because it seems like this wouldn't work wouldn't work well if the person was homeless.
It actually, 60% of our patients start homeless. And I have that data and it's grown to 63% because cost of living everywhere is increased, but in South Florida, it's completely out of control. So our homeless patients come to this.
How do you get your patients to you?
So we have a grant, a separate grant through our own county that helps with transportation costs. So we can transport people up to $75 a year using Uber or bus passes. And we have care coordinators on the very first day who start working with them to solve that problem. And a lot of them rely on public transport.
Thanks.
And we try to get them in our county. You can get a month-long bus pass if you have homeless status for less than $10 a month. So we try to help them secure funds from the different, we work closely with our homeless shelter in our county, and they have funds for that. So they'll help the patient get a month-long bus pass that can allow them to navigate where we live. Now, I appreciate that some of the counties are very rural, and I can suggest too that there's a whole way to do this over Zoom that we'll talk about later, because I'm not in a rural county at this time. Okay. Any other questions? That was a good question. But again, one of the reasons we're working on transportation with them from the get is that's also going to allow them to get a job. Transportation is necessary for them to get their license, which half our patients start without a driver's license. So these are life things that they need to start working on too in order to be successful citizens. And most of the patients want to be on their own and they want to have self-sufficiency, and they can. So we're helping them along the way with all of this. And I'm not getting into all of those accessory services today in this talk in our clinic, but I'm mostly focused on how to provide efficient medication-assisted treatment with psychosocial interventions at the same time. Anybody else have questions?
The funding that you got for the transportation, was that strictly your county or was that a grant?
It was strictly our county.
Okay.
But we're always, like you guys, we're always looking for any and all funding sources for social interventions. I will tell you too, on the side, our homeless outreach program in our county, we developed a relationship with them, and they now come to the clinic in the mornings to meet with patients in our clinic who are homeless and substance users to help already start them linked to housing. That agency is totally separate from our clinic, but we've developed a relationship where they come and we have a lounge where they sit and we bring patients to them. I say, hey, this is Mr. Jones. He is new to us. We're so happy he's here. He needs some assistance with how to get signed up on a list to start working on his housing problem. Okay, so I highly encourage, that's another part of the coordination the clinic should be the hub for all of those social agencies to come to these patients. And it's very possible. And it actually makes a wonderful working relationship. I love working with our homeless outreach team from the county. Anything else? Okay. So yeah, I just want to make one more mention of throughput. How do you always keep open slots for new patients on the schedule? You really have to have a high walk-in volume. And most days we start our clinic, we don't have very many patients on the schedule, and they just add on all day long. So we have a lot of walk-ins, and I would say these clinics function best when they're partially scheduled and partially sort of urgent care-ish, because people come when they need help. And it's very important to have same-day access, both for new patients and for return visits who walk in 3 days after they were scheduled. Okay. So I want to mention, actually, let's move this up first. Sorry. I'm going to go through this. So this is a bit of a boring slide, but it's very important. So what is the group-based addiction treatment operations and flow? Okay. So in our electronic medical system, we've done this in Epic and in Athena. If any of you guys have Athena where you are, but this is possible in a lot of different EMRs. We have a group template for the social worker, mental health counselor with 12 scheduled slots and 3 walk-in slots. And we also have a group template for the prescriber, and that can be a psychiatrist or primary care with 12 on the schedule and 3 walk-in slots. We have, so there's a prescriber, there's a social worker, mental health counselor who's doing the group. There's a prescriber who's going to give the meds during group. There's 2 MAs. So 1 MA is taking the patients after check-in and getting their urine before group starts and entering those results. The other MA is with the prescriber in the room when they pull the patient out for their quick medication visit. In our clinic, we have such volume, we have 3 groups per day, which are fairly full. So that means we can see up to 45 return patients a day with 1 social worker and 1 prescriber. So this has worked. We've done it for 2 years, and it allows us to have a lot of volume to see return visits. So you might say, well, why would you have a walk-in to group? So what does the walk-in look like? And the walk-ins get utilized frequently. Patient was supposed to be here last week. We don't know what happened. They show up today. They say, something happened. I need to get I'm out of medications. I need medications. We put them on that walk-in slot in the group. They get that group and they get their medications during that group. Okay. So it allows us to see that's 9 walk-ins a day for the return visits. Each group, one thing we were having when we were doing this all individually is, like I said, the cycle times in the waiting room were horrendous because we'd have one crisis after another, and we couldn't keep up with the schedule, both the prescriber as well as the therapist. So we were having a lot of agitation of people saying, gosh, I just got this, entry-level job. I'm a felon and I'm here for 3 hours. We had a big heart because we wanted to see everybody who walked in, but doing that with the staff that we had was very difficult. So each group is a 2-hour slot. And within that slot, we tell people, we guarantee we'll start on time, we'll end on time. All of your stuff will be done in that 2 hours at most. But frequently, if we have less patients, let's say we can see up to 15, but let's say we have 8 that day or 7, we usually finish in 90 minutes or less if the group is smaller. So we start and end on time. We're very, very tight with that frame. On the new patient side, sometimes patients wait a little bit because we're always trying to, fit them into the schedule. So the patients appreciate that, because if they have an entry-level construction job or restaurant job, they'll say, listen, on Wednesdays, I go from 8 to 10. That's it. I know I'll be at work at 10:15. And we have 3 groups a day. So we have different scheduled groups. And if you guys have the capacity to staff at night, you could do this in an evening to help with patients who are working, or on a Saturday. That's up to you and your staffing. But patients are also expected to be on time if they're late past 15 minutes. So if the group starts at 8 and they come in 8:30, they have to go to the 10:40 group. And this allows the group to be meaningful for the people who are there, us to run on time. We cannot guarantee that we're going to be on time if they're not on time. So we're on time and the patient is on time. And I always say that this wonderful, I'm an addiction psychiatrist. I love substance use in the sense that not only is it about treating the substance, but a lot of these patients, while they've been using for 5 to 10 years, they haven't developed emotionally. When you're numb because you're using, you're not developing skills of how to deal with waiting in line, how to deal with schedules, how to deal with making appointments. So there's kind of this failure to launch scenario that when sometimes I have a 32-year-old who walks in, they've been using since they were 22 and they're developmentally still 22. So a lot of the being on time for group, us being on time for group, is that expectation that the world has for them. You got to be on time for work. You got to have your documents in order. And so we work in these little ways to help the patient really start to, and if they're having trouble with that, we start to identify what the issues are. If they're true psychosocial issues, we have care coordinators who work all day on their psychosocial issues, linking them to different supports that get them started. But you have to have some expectations for patients to grow. And they want to grow and they want to get better. So the patients are checked in the first 15 minutes. The medical assistant gets all the urines before group. Group starts at a quarter after. There's always group rules on the wall. We don't review them every group, but they're in a big framed plaque on our wall. And that kind of helps everybody establish some order. During the group, the medical assistant pulls each patient out one at a time and gets their vitals, and they are checking their E-forces. So the first MA was getting the urines and are already in the chart. The second MA, who's with the prescriber, gets the vitals, and they also get that, they put the E-force results into the computer, and sometimes the prescriber does verify that. And then the prescriber does a 99212 visit, which is a 10-minute or less visit, only focused on the MAT medications. And they have a pre-visit form that they get from the patient that the patient filled out in the first 15 minutes, which I'll go. Then let me make the last point. They only do the MAT meds. That's Suboxone, Sublocade, Vivitrol, Naltrexone, or if they're on a benzo taper. They do not address, and they will do refills. If there is a patient who says, gosh, I have this wound today, or I'm having, hallucinations, we have walk-in slots on the primary care schedule and the psychiatric schedule that can be done after group. So we do not get into all of that in these short visits. We focus that way. The patients who are there to get their MAT, they're there to go back to work, they don't get held up. And then those patients who have a particular extra issue, a lot of them are willing to wait after group because they do need to get something addressed, and we will address that with them. So this is a very busy slide and it goes over a lot. I have some pictures. This is just quickly, not going to go over all the group rules, but this is what's posted on the wall in the group room. And this is more of a picture of how that flow goes that I just did with narrative that you can kind of review. And I can make these slides available, so don't stress if you don't get it all in. And that pre-group form. So this is really important, and I want to share this with you. So I spent a lot of time with my electronic medical record development to make templates for the prescriber that are very quick and easy to fill out for this type of visit. So when the patient walks into the group room in that first 15 minutes, they have a clipboard with 4 pieces of information, okay? One of them is this form that they fill out every time they come. The second one is a pre-group journaling exercise. The third one is the in-group exercise, and the fourth one is their homework. So the patients know to expect this, and I put it right here. So this pre-group assessment, the patient has already filled out. They bring it to the prescriber in that quick visit, and this is exactly how the prescriber's history of present illness is documented in our electronic medical system. So with this information, it allows the patient or the prescriber to quickly see how the patient's doing today in a quick way. And here's a form. I couldn't cut and paste the whole thing, but these are the 12 questions that we ask so that we can get a sense of how this person is doing. As you can see, and the prescriber can focus and address the things that need to be addressed and not have to ask and address everything that isn't being addressed. So if they put another medical issue, another psychiatric issue, or other concerns, and it seems like they need an appointment after, we'll talk to the patient and say, you seem like you really need to be seen today. You're having chest pain. So we'll have them seen right after the visit or right away, actually, by a medical provider if it's chest pain. And sort of we track this. And so this allows the visit to be smoother and faster for the prescriber. And like I said, it directly links to what they input into their note. So I'll pause there because that's sort of some of the flow. Does anybody have questions about that? Okay. So going back, so while we're pulling people out, and I want to talk about the setup. We've worked in existing public health buildings for years. We used to have our group room was the waiting room in one of the public health buildings that was pretty institutional. So we would pull them out through the door into an exam room. We are lucky that our FQHC built us a custom built clinic with a group room that has a clinic door attached with a glass wall, so we can see the patient and bring them out one at a time quietly. So the prescriber is able to see who's not talking in group, who seems to be listening and ready for their visit. And we really keep them in the back with the prescriber and the MA for 5 to 10 minutes because we want them to get the material that's happening in group. So what's happening during group? Like I said, the patient has this clipboard. They do this right away. They're working on the pre-journal exercise, which is typically a thoughtful question to get their mind working on what's going to be happening in that group. Group is delivered in 50 to 55 minutes. We built a curriculum based on SMART recovery, and you might ask why we did SMART. SMART is CBT based for substance use disorders, and it's also very cheap to train each prescriber. So it was like $200. I think it was like $180 per social worker for us to give them the full SMART recovery training. We also put some motivational interviewing materials and mindfulness in there. Group always starts with a mindfulness activity in the first 5 minutes to help the patients kind of wind or focus on what's going on. And then it goes into the didactic, which is run by the social worker or licensed mental health counselor. And then they're given homework to give them thoughts to work on at home after group. So with that, I'm going to show you one of our manuals. It's a 16-week manual. Like I said, a lot of the materials were taken from SMART Recovery. Now this is month 1, okay? So I worked on this with our lead social worker, and I just want to give you a general group session outline. And it's actually the first 15 minutes. I'm so sorry we changed this. Pre-group session, the patient is checking in, they're doing their clipboards, they're seeing the nurse. The group starts on time. We do have coffee and light snacks. Patients love that, and low lighting. And in 5 minutes, there's a mindfulness exercise from the social worker or mental health counselor's choosing. For 15 minutes, they do check-ins for highs and lows. So what were the highs this week? What were the lows? And there's a lot of discussion, and that follows more of like a processing group that you would see in a 12-step approach. Okay. This shouldn't run for more than 15 to 20 minutes, but it's very important. And a lot of times people talk about the homework, a concept that was discussed last time. Then the 5 to 10 minutes is spent with the addiction BHC teaching the didactic. 10 to 15 minutes is spent with the patients practicing it in the group. And then there's a 5-minute wrap up. And in post group, the patients are making their follow-up appointments with registration. They're getting their medications, and they're having as needed discussions. So in terms of our first month, as you can see, month 1 here is building motivation and maintaining motivation. And we have a category for each week, and it builds for the entire month. And month 2 is about coping with urges, right? So month 3 is about managing thoughts, feelings, and behaviors. And month 4 is living a balanced life. And we repeat this cycle every 16 weeks. We start over. So you'll see each group has a pre-group, in-group, and homework assignment. I'm going to show you 1 week so that you can get a sense. Here's our, this is our session 1, week 1, building and maintaining motivation, stages of change. Because a lot of these patients aren't ready to quit using, right? So we wanted a motivational interviewing kind of month as part of this. And they go over these stages of change. So this is the pre-group journal exercise that they're doing. So please describe a time that you wanted to make a change, but simply couldn't do it. What do you think made it difficult to change? In week 1, here's what they review. They review this concept in the group and talk about it. And the therapist has them analyze themselves. Where are they at with their stage of change? And they get a homework assignment, which is a consumption and goal log. And they sort of put their own goals, whatever they are. Some of the patients, it's not to quit, it's to reduce something. Some of their goals are to figure out their goals. So this is what they take home with them. And as you can see, when you go into week 2, it builds on week 1. And we have the same thing with different content. So there's a different pre-group journal exercise, which talks about values. And then they go through a hierarchy of values, which is right from the SMART Recovery Manual. And they have homework, again, to do this consumption and goal log. So you can see this goes on for 16 weeks, but it's very, it's nice from a training perspective. If you have interns, it works really well. And it's manualized based on a lot of manuals that have been effective. So we took Smart Recovery, and you can just do Smart Recovery. They have great materials. And it's very user friendly. And then the entire week, Monday through Friday, the same theme is going on. So if you have a social worker who calls out one day, the other social worker can quickly fill in because they don't have to plan group. It's all right there for them. So we also considered that because during COVID, we had a lot of people not at work, not coming in, and we were still trying to maintain this program. So any questions about that? Okay. So we've been doing this now for 2 years, and what we've seen, we've definitely addressed some problems. We also had consultants, outside consultants from California help us a little bit. We've seen cycle time decreased significantly. More patients are seen in a day because we are public health, we don't turn people away. We have over 500 patients in this program, and we have 3 social workers. We have 1 social worker assigned a group for the day. We have 1 social worker doing intakes. And we have 1 social worker doing those in-between appointments. If we get more, we have multiple positions posted for other social workers or licensed mental health counselors that haven't been filled because we can't find them. If we get that, we'll add individual therapy as an option for those patients. We can't offer it now because we really are bare bones with our staffing. This is consistent evidence-based therapy, and the patients are happy as they have a frame, they know what to expect, and they have a structure. The staff is happy because they see the progression of patients. The things that happen in the group room are amazing. They have a lot of insights about their motivation. They have a lot of thoughtfulness. What we have is we have a mix in each group. So if you're on 4 weeks, right, you only come to group once a month because you get 4 weeks of medication. So someone like that, they're in group with somebody who's very new. And the beauty of that is that old recovery person, like in AA, is sort of mentoring and saying, I was where you were at. I had that problem. This is how I thought about it. And they start to help each other. And that MAT is not compromised at all. So it's not that we are requiring psychosocial. It's that we have developed a system that psychosocial is part of your MAT appointment. And I think it's been pretty neat and novel to help us. I want to talk about Zoom groups. So we're still evolving this program a little bit. We used to require a Zoom group in between, but we just made the decision last week. So if someone goes to 2 and 3 weeks, we're having trouble getting them to show up to the Zoom group in between. We were requiring it and even phasing them down if they didn't, but we think that that's not necessary. So we're going to drop that requirement and probably offer it twice a week in the same curriculum to those that need it or want it. You could potentially, though, if you're in a rural county where public transportation is lacking and you really do have these barriers, you could offer Zoom group as part of your televisit if you guys have decided as an organization to do tele-Suboxone. My attorneys at my group are nervous about that, but I know some places are doing it. I know in Gulf and Manatee, they were considering it. The literature supports it, but like I said, it comes down to the attorneys. So I want to finish with some data to help with burnout from the staff. Okay, so there was a very good question by Deborah last week about these patients who, let's just describe one patient, and there's many people like this. They come in originally, you get them started, let's say they're started on 16 to 24 milligrams of Suboxone. They are having less overdoses, so you feel good about that. But the patient comes in every time on fentanyl, and they don't seem to be making progress in other parts of their life. And they maybe disappear for a while and then come back and disappear and come back. So you guys have become familiar with this at this point, which is our Brief Addiction Monitor dashboard. I wanted to show you, there's two things I want to show you. This is time interval in terms of months. So 0, 3, 6, 9, 12, 15, 18 months, all the way out to 5 years. But as you can see, I put on this one for you all to pay attention to the number of patients at each interval. So if you look at 0 months, we have 2,655 surveys. And this is not unique patients. So I want to make sure you're clear. It's the number of surveys. But then at month 3, it drops to 695 and then 315 at month 6, right? So when you look at that, when I looked at that, I said, geez, it's not that we're not retaining people, because I have another statistic about, we talked about readmissions at the beginning. So I have lots of patients who come for 0 and 3 months. They leave for, they disappear for 4 months. They come back and they do a 0 and 3 month BAM again. Okay, that's great. Those patients are getting counted multiple times in these two categories. So my data analyst and I said, well, let's rework the data where we say, forget the time interval. I don't care if you did a 0 or 3 months. If you did a 0 and a 3 month survey 3 times, so that means you've done 6 surveys. We want to look at the total number of BAMs you've completed, regardless of when it was. Whether you started at 0 and went all the way to 12 months, or you started at 0 and you readmitted yourself 4 times and only got to the 3rd month. So we said, let's just look at the number of BAMs that a patient did. Okay, forget that. What you see here is the exact same trend, which I was happy to see. And you also see a significant spreading out of the number of patients in each point. So it shows that regardless, what this said to me as a clinician who also gets frustrated, I'm human and not always, it's hard to see the same thing over and over again. What it said to me is regardless of how many times that person readmits to EMS, the ED, the clinic, because we do have frequent flyers who go to the ER frequently. If they keep showing up over and over again, the more we get these BAMs done, the more they come to the clinic, the better they get. And it helped me from a burnout standpoint to say, I'm not doing something useless here. Every time they show up for whatever reason, whether it's their follow-up that they were supposed to be at or a readmission, over time, all of these metrics are starting to improve. And a lot of these have to do with their thriving in life. And the longer you do these programs, you're going to have patients who for 18 months were just struggling. And then they got it and they turn it around. We have many patients like that after doing this for 5 or 6 years in our program. And they're wonderful in group because they really help the new people to see a long-term kind of case for themselves. The other thing is we were seeing some retention issues after 4 to 6 visits. And we started piecing out in 1 month. This is very early data, but I want to show it to you to alleviate some things. We're not ready for this for prime time, and we're still trying to hash it out throughout the time. But what we found was we isolated the 2 issues of homelessness and alcohol. So, and we have a lot of patients who use opiates and alcohol. We have a lot of that. So a lot of people I've heard in talks say, oh no, you don't get, opioid users don't use alcohol. Absolutely they do. We have quite a few of those. So those are 2 difficult issues. And when we teased out homelessness as an identifying factor, what you're looking at here is success of patients enrolled and success of total touches. So patients who actively get enrolled, if they say yes to homeless, it's 44%. If they say no to homeless, it's 75%. And those are patients who show up at the clinic. And if alcohol is involved at all, only 29% stay in the program and 67% stay in the program. And this data, by the way, is all these patients have opiate problems as well. So if we have someone with stable housing, no alcohol use disorder, and they have an opiate problem on MAT, 70% of the patients stay enrolled. And 59% we even talk to stay in the program. If they have homelessness and alcohol and opioids, 0% stay after 4 to 6 visits in that 1 month. We identified January of 2022, and we're working on other months to see if that's an outlier. I'm not showing that as some definitive thing. I'm sharing our internal stuff to tell you guys that there are other factors that also affect retention, and we have to start to understand those. But we started with the BAM, we started with novel systems to address care, and we know that this system works too. My team is much happier. We have much better retention of our staff because they can finish their day. And I can tell you that we can work with less staff, which is always good because these public health programs are expensive and hard to fund. So it brings efficiency on the table. So with that, that's all I have to show you guys today, but I wanted to stop there and entertain questions, comments. discussion at this point. And thank you for listening.
Hi, Doc. This is Michael Harris with the Marion County Hospital District.
Mhm.
I had heard that you had mentioned that sometimes that your MA and your provider would check the E-Force. I was curious to understand what you meant by that. Why, in the sense of why aren't they doing it all the time?
Are they checking the E-Force every visit?
Yes,
that-
I guess that's what I'm at.
Yes, we are. And what happens is as a prescriber, you can designate a nurse or an MA to be allowed to access eForce. So my flow for that is, and I obviously am responsible for that. So what we do is a lot of times the medical assistant who's assigned to the group for the day checks all the eForces of the patient on the schedule before. It's like a pre-visit planning. And he or she has it ready to go. But what I do is if it's negative, when I have a new MA who's in training, I check all of their eForces as my own audit to make sure that they know how they're doing it. Then, and in our documentation, we have a place where they can put we call it a positive eForce, meaning there's something on there that's concerning, or a negative eForce. So I do my own audits of my MAs because I'm ultimately responsible. If the MA says that anything is positive, meaning there was a concerning issue on the eForce, then I actually pull it up myself and I take my own look at it. And we're working with our EMR to get the PDMP or the eForce embedded into the electronic medical system. A lot of places can do that. You have to ask for it, but they can embed the PDMP or the eForce into the chart. So you don't even have to log in separately. It just pulls up with the chart. Okay.
What is your recommendation for if I may use the term, a green provider due to a provider shortage, and they have a high anxiety about what they may see on eForce and set a very low threshold for what they consider to be positive?
I want to make sure, I'm having a little bit of a hard time hearing you, so I want to make sure I repeat that appropriately. You're saying, what do you do about having less prescribers for staffing and who are comfortable? What do they do if they see a positive eForce and they're actively giving the patient buprenorphine? Is that your question?
Right. Because a lot of the prescribers that we are seeing in our rural areas are not as, they don't have the experience, I would say, that you do or many others who have been in the field for a while do. So their anxiety levels are much higher
Yes.
when it comes to.
So one of the things that I've done, because I've worked and hired a lot of prescribers who 4 or 5 years ago, I needed more help. I was doing this by myself, and we now have like 5 or 6 people, but they said, hell no, I'm not doing this. So what I did as a leader is procedural support. So procedural support where there are rules about what happens. So let's say somebody comes in with a positive eForce, but we have them on buprenorphine and they've just pulled, in our clinic, you're not allowed to be, we don't allow coexisting Xanax and benzos because there's no evidence supporting benzo use in my review of literature over and over again for anxiety. So in fact, it seems to make things worse. So let's say they're pulling Xanax or Adderall from an outside prescriber, because we do require the patients come to just us for all of that. We do have a few patients on stimulants, not a lot. But bottom line is it's positive, meaning they got an outside prescriber. And every county has some people who prescribe a lot of controlled substances to people. So if that's positive, what we do is we require that the patient, in order to stay on board, sign a release of information so that we can communicate with that prescriber. Okay, so if the patient comes in and they said, I say, hey, I saw this on eForce, what's going on? Oh, well, okay, I did get it, but I'm selling it. A lot of times they're selling it. They're not taking it. They're selling it. And I said,
that's what we find a lot too.
And they say, I said, it's not even in your urine. And they said, well, I'm selling it. I'm being honest with you. I get a lot of money for this Xanax that I get. I said, all right, cool. Thank you for telling me. You know that there's you and there's your substance use problem. And I'm friends with you, and you came here to get help. And they go, yeah. And I said, we're on the same team and we're trying to fight that thing that's kind of taking you over. And I think in this way, it takes you over a little bit. You sign the release. We're going to keep them on 1 week if they have the release. And we're going to do motivational interviewing for a while to try to say, hey, at some point, if you can't get off of this benzo, or stop pulling this, we are going to slowly taper. We also reach out to that prescriber and we let them know what's going on with the release. If the patient says, I refuse to sign the release, that is a stopgap for me as a prescriber. I'll say, listen, I hear you, but I need to at least be able to communicate. And if they say I won't do it, we'll try one, or I'll say, okay, tell me next week if you're willing, but this is where I have to draw the line. So the next week, if they come in, they say, I'm not signing a release. I had one patient recently say, look, I'm selling it. It provides me income. And so I say, well, I'm uncomfortable with this. So I'm going to taper you very slowly, 2 milligrams a week. And if you continue to pull that script, 95% of patients over the last 5 years I've done that with have said, by the time, if they were on 16 and we got down to 12 or 10, they say, okay, I'm going to stop pulling the script.
This is exactly what this is. Thank you so much, because this is that area that that people don't like to talk about, but is so common. I appreciate that. That answers my question.
Yeah, and listen, I have to be careful on this call because the literature does support that if somebody comes in on a lot of benzos, you should still start MAT, and we do start MAT. We just require that release of information.
I love that procedural.
Yeah. And we have that in a procedure. So my primary care docs who get very nervous about this, they feel comfortable because they know exactly what they're going to do. And I tell them, we're not going to rip the patient off. We're not going to say, we're not giving you Suboxone. That's putting them into withdrawal and making them at risk for going to the street. So I say, okay,
right,
drop them by 2 milligrams a week. It might take us 8 weeks to get to 0. But in the meantime, we're talking to the patient saying, you really want to do this? I mean, you were doing so much better. We're doing motivational interviewing at each visit, and they do not progress beyond a week. And the 5% of patients who absolutely refuse to give us the release, the next week we'll do an observed urine, not because we're cops, not because we're trying to catch anybody, but we're worried about that person. We've had quite a few patients faking it. And if it's not there, typically they're selling everything. So that's how I don't get stressed about somebody using my script in a wrong way. I know eventually over time it will declare itself. And if you have, we can do discussions about that part. I have procedures even for that have really helped my primary care feel more comfortable with what to do with these comorbid, difficult situations. Does that make sense?
Yes, thank you so much.
Yeah, and it's also in our legal consent when the patient starts the program that they can't be pulling scripts from outside prescribers for controlled substances. So I have a lot of patients who say, well, I go to an outside psychiatrist, I'm getting Adderall. A lot of times that psychiatrist has no idea that they have a substance use problem. So we get the release for them, and then we say, well, we'll do an evaluation in about 3 weeks when things have calmed down with your opioids, where we'll evaluate and potentially consider yes or no to prescribing a stimulant in-house. But to keep that drug, that doctor shopping, we really, if the DEA comes to some of your organizations, you really do have to address why are you allowing doctor shopping? They'll look at eForce and look at your prescribing, and you have to be able to answer that question as well. Okay?
100%. Thank you.
No problem. And I can get more into detail if you need. Anybody else?
I have a question about your fentanyl. What is your procedure with somebody coming in with a positive screen for fentanyl?
Meaning, so we treat that like any opioid. So we start them on MAT. You mean if they're on MAT and they come in with fentanyl?
Or no, they're starting and they've come over, say, like from the paramedicine program, and they come to the clinic to continue their care, and they're still, it's been like 3 days, 4 days they've been on Bupe, and they're still showing positive for fentanyl. And then what do you do at subsequent appointments as far as the fentanyl levels?
So I'm going to pull some materials up while we talk. Can you guys still see my screen or no? Did I stop sharing? Let me share my screen.
No.
Okay, so a couple things. First of all, the metabolism.
Also, Dr. Phillips, this is Deborah again. Also fentanyl that comes up 2 or 3 months after they're in the program.
Okay,
also.
So let's talk about days of fentanyl positive. The way fentanyl's metabolism is, it's long lasting. Okay, it lives in so it's not the pure fentanyl that you get in a hospital when you have surgery by anesthesia. That actually has a short acting life. But this lives in the fat cells, and there's other components on it from the drug dealers that are making it linger. So there's a lot of evidence that it lingers for a long time. So somebody who comes in 3 days after with a positive fentanyl screen 3 days after, it's possible they didn't use and it's still lingering from their original use. Okay, so it does take a while to become negative. The other thing is these fentanyl tests, I haven't been shy about this. It's all we have, but they have a lot of false positives. Okay, so when a patient swears up and down to me after 3 days, I don't check it, but like, let's say it's been 2 weeks or 3 months to your point, and they said, I swear I'm not using fentanyl. They also look well clinically and they don't look like they're using. I'll send it out to Quest as a confirmation. And about half the time it is a false positive. So remember, we're using these fentanyl tests because it's all we have, but they do have a high false positive rate. And so you do want to, every once in a while send it out and see. And one thing we do, every shipment we get, we send out from that unit shipment a confirmation because there is no control testing. So that's another thing to keep in mind. And then the third possibility is that they are using fentanyl and taking buprenorphine. Okay. So in that case, if the patient says, you know what, yeah, you got me on bupe, let me tell you, that stuff is really helping me. I haven't overdosed at all this week, which for some patients is a huge win, right? Some of these patients are overdosing twice in a week. But they say, I'm using less fentanyl. And usually they are. So it's harm reduction. So I think about it in that I say, well, listen, okay, you're still using, so how are you using? What time are you using? I start addressing their dosing schedules. So for example, although buprenorphine has been marketed to be able to be taken once a day, a lot of patients need it 3 times a day. So if they're on 24 and they're saying, well, I take it all in the morning, I'll say, well, let's try spacing it out. If they say, well, I like using fentanyl at night because, I have no friends and it's the only thing that's been there for me. And it's just a habit that I love to take my fentanyl and go to bed. Okay, well, then that needs more of a psychological intervention, right? So, I think that I really do diagnose why the patient keeps using fentanyl. And I'll say, what is it doing for you? What do you like about it? You're still using it a little bit. I'm so glad you've reduced. I'm so glad that you're not overdosing. And I'm so glad you're coming to our clinic. But what do you like about it that you can't let it go? And there's a lot of things that patients come up with. They have relationships with these drugs. And for a lot of patients, again, it's the only thing that's there to soothe them when they're down. So you need to address it in whatever the capacity, or perhaps they're on 16 and they really need a higher dose. They're having night sweats. They're good all day, but they're sweating through their sheets at night and they're going into withdrawal all night and having diarrhea that prevents them from sleeping. Maybe they need a higher dose. Maybe Suboxone's not holding them and they need methadone. I will start to have a conversation with them and say, methadone works really well. It's a full agonist and we can dose higher than, there aren't any limits on it. This might be a better fit for you. I used to work in a methadone clinic and some patients they have a different metabolism. So the point is that you really have to, the prescriber has to get into it with the patient about what is causing them to keep using fentanyl. And what could be used to address that. If it's, I'm depressed, they probably need a psych visit. If it's, like I said, a psychological reason, maybe if you have extra therapists who could do some individual sessions with them. So you really, it's one medication and it's one drug, but there's a lot of meaning behind that drug for that patient. So you got to get into it with them. Maybe it's a dose issue. Maybe it's a false positive. And so I would encourage you, before throwing up your hands and saying, what the hell, start identifying the comorbid use, right? Maybe a toxic relationship that, it's the only thing they like to do together. And so the relationship needs to be targeted. So this becomes very complicated as patients get stabilized and better. The, people who get into long-term recovery start addressing those really deep issues. But we do keep people alive with medication. So we got to do that. I can only have these conversations with live people. I'm showing this screen right here for our high dose induction protocol. We found it's much easier and less precipitated withdrawal than doing it by the low dose microinduction that we used to do. So for fentanyl. Any other questions? And I hope that answered your question, Deborah. Any other comments?
I guess the only question I would have would be is if would like to reach out to you to get in, if I needed to reach out to you to get into more depth on some of those gray areas.
Yeah.
How would that be possible?
Easy. Email Shannon with the request.
Okay.
If there's a request from you, there's probably a request. That's how Deborah was brave enough to admit what they were struggling with. And I say brave because nobody here has to pretend that this is easy work. I mean, it sounds great on paper, but it's tough every day and day in and day out. And it burns people out. So if you're having that problem, probably a lot of people are, and we can develop another talk like this on a very specific topic that talks about it, where we could bring up, things like pitfalls in buprenorphine prescribing, or fears of buprenorphine prescribing from the part of the clinicians, and sort of problem solving things. And there's lots of, the more you develop your procedures, you can bring prescribers on, and prescribers are much more comfortable when they have that legal procedural support that makes sense.
Thank you.
So please request to Shannon, and that for the next 6 months, I'm here for that. So please use it.
Dr. Phillips, hi, this is Isabella from Halifax Hospital.
Hi.
And our providers are having concerns doing the induction in the emergency department because
Right.
it does cause them to start having withdrawal symptoms. And they've been told that we need to monitor them for 24 hours. If we do the induction in the emergency room. Is that, I hadn't read that anywhere, but.
So some of this is really, fast evolving literature, because the drug culture is evolving faster than we can research it, right? So I appreciate the question. What happened with when fentanyl first came on the market, we were waiting for 24 hours for people to get started, and then starting them on 2 milligrams or 1 milligram, and then building slowly. So they were sitting in emergency rooms. In our own Palm Beach program, number one, patients would leave sometimes before they could get to that point. They were like,
right.
This, I feel like crap. Second, they'd get nasty for 24 hours with ER staff, and they're like, you know what? I don't want to do this. I don't need to do this. I'm going to go see my other patients who are nice to me. Number three, it is very expensive to have these long waits in emergency rooms.
Right.
So I'm so glad that things have evolved. These high dose inductions, which we're doing in the ER, patient can be recently Narcan within 2 hours. I can show you, we just did the EMS protocol. It's a resource posted on the SharePoint right now.
I actually just downloaded that, but yes.
Yep. But that high dose induction picture I just showed you is our ER docs now are saying, oh my God, they're coming in, even if they use 4 hours ago, we start the 16. If they have any problems after 25 minutes, we start another 8. If they get to 24, a lot of times they override it, but you can override it up to 32.
Wow.
That doesn't mean the patient's going to be on a maintenance dose of 32.
Exactly.
We're just overriding that fentanyl. And then if they're stable, they're nicer, they're happier, they're discharged faster. Right. So for the administrators in the hospital who don't like,
they're feeling good, right?
Yeah. And ER docs love that too, because it's quick, it's great. And then we like it at the clinic too, because on the clinic side, when I get a patient who comes into the clinic after being in the ER for 3 days, they are not nice, and they're not. So I think that trying this high dose induction is the solution, and you can do that pretty quickly after they use. And I would encourage it. And I would just say with confidence to patients, this is going to, and if you get a little bit sick, we're going to put you on 8, and we're going to give you another 8.
Right. So that's how you override those withdrawal symptoms, would be by just giving them another dose.
Yeah. And I would say if they get on a high dose, maybe they're monitored for an hour to make sure that they're okay. And then they're sent to the clinic for their maintenance dosing. Okay.
Perfect. And my other question, and I'm not sure if you are the one to speak to this, but I read in the omnibus bill that was recently passed in November. Oops.
Yeah.
That it was approved that the providers no longer need the training or a waiver to prescribe.
Yes, I saw that too. It's very hot off the presses that the federal waiver mandate is lifted. And that's great news for more access to care. What it said in the article is that we still have to reconcile that with Florida state law.
Okay.
So Dr. Shepke's actually on that. He's in the Department of Health, and hopefully they'll come to some resolution as to what that means in terms of Florida law. And I will bring that back, that it would be good for us to send out a blast about how to reconcile the federal new mandate with the Florida law so that everyone's clear.
Right.
But it's great. And this is the ER high dose induction that we're doing in the clinic. And you can see it says max 32 milligrams in 24 hours.
Yes, I actually did a snippet of that because I was going to email it to our providers.
Yeah,
So-
yeah. Now, there are patients who refuse it, and we still do the low dose induction. And I have a
Right.
separate low dose induction, but I tell them this is you're gonna feel better much faster. And so for the low dose induction, often we do it at home. We do home inductions for those
Sure.
patients. So we'll send them home with a bunch of 2 milligram tablets.
That's pretty much what we've been doing, I think.
Right.
Couple of,
So I was.
So when it comes to Dr. Shetty, do you think it may just be a simple 2-year, whenever they have to renew the DEA, if you're able to prescribe Schedule 2 or whatever, that it'll be, you just take the 8-hour course, or like how would we know that providers are capable of doing it?
Well, first of all, let's go back before this was just given out from Biden.
right,
This was a huge misconception with a lot of people. You can prescribe up to 3 days of bupe without a waiver, even before
right,
this happened. So from an ER and EMS standpoint, you have
Always
no
been an
problems already, none. But most of the problems were on the clinic side. So that was a sort of a misnomer. And then there was also this form that was developed to say, if you're a hospitalist-based doctor and you're prescribing maybe up to 30 patients, so let's say you're rounding on people and you have like 3 people or 4 people at a time who are in the hospital for 7 days, up to 30 patients, there's a form you can fill out right away and you're granted that you can prescribe up to 30 patients. So for a hospital-based psychiatrist, ER psychiatrist, or EMS, there really are no restrictions or need for an X waiver. The prescribers in the clinics did need it, and it's looking like that's being lifted. So I still think the X waiver training is very helpful because so I give my providers when they onboard a full day to do it because they learn a lot in that training. That is, it makes them feel more comfortable, but the fact that it's not a requirement is great.
I find that even the clinicians, if you have them just do the training too, even though they can't prescribe, like it educates them so much in understanding the process and what it means for the patient too.
Yeah, and I want to point out a website to you guys that's completely free. It's sponsored by ASAM. Have you guys seen this website before?
Yes.
Okay, so this education and training has a SUD 101 core curriculum. I've had many, many primary care providers who have no idea about substance use who start the job. They're excited, but they don't know anything. It has 33 free lectures, PowerPoints on tons of topics, a whole curriculum that's absolutely free to everyone to go over all sorts of topics in substance use. So if you have a very green person, these are free resources for you. There's a chronic pain curriculum. There's SUD for a healthcare team. So they have a training module for people who are like support staff. So sometimes it's really important that your front desk and your MAs understand this too. And this is more geared towards them. Okay. Because everybody has to understand what's going on for this to work. So please look up this pcssnow.org. It has obviously the X waiver, but it has a lot of great free stuff. And this is all driven by ASAM. And you should definitely take advantage, and you can make it part of your onboarding. If somebody's coming on to work in a substance use setting, you could say, I want you to watch these videos. They're just good to know. All right. Anything else? These are great questions. And if you want, Isabella, if you show these protocols and they want more, we can certainly develop, and we're recording these and we're going to put them on the SharePoint.
Thank you.
So that we can do something for your ER staff. We're actually developing something for the ER teams in Escambia. So
Okay.
if those loop videos get shared with you, you could probably share them as well.
Right, yes, that would be really good because we have a large ER department with many different providers.
Yeah, so
it
I
would
did a
be
lot
helpful.
I've done a lot of ER training, and the issue I have is the day staff is all on board. Then you've got
Right,
then you've got the 2 a.m. doc who's contracting, he's only there twice a month, and he says, I don't know,
That's right.
I'm not treating the patient. So you can require those videos of those patients if they're on loop.
yes, and they can be added to their yearly mandatory CBLs, and that I mean, they have to do other trainings, so
Same with,
that would
yeah,
be great.
same with Right, see it, same with EMS shift workers. Sometimes you get an EMS person who's like, I don't know what this is about, I'm not doing this.
Perfect. Thank
Okay.
you.
Thank you, Isabella. Anybody else? Well, thank you all so much. And if you have follow-up topics, like we could do, you know, like the View, we could do hot topics in prescribing buprenorphine, and we could have a whole, you know, hour so that you could say, well, these are the hot topics that come up. The pharmacy has this, you know, I've had issues. I've had to have meetings with pharmacists who said, I'm not prescribing it. I don't care what you put in there. And so there's a lot of hot topics that come up with this medication that need to be addressed in order for people to feel comfortable, and you can proceduralize it. So please send those hot topics to Shannon. I'm already thinking that it might be a good idea to do a hot topics lecture for everybody.
Sounds good.
All right, thank you.
Thank you very much.